Welcome to the Pomerantz Mentor Series of vignettes sponsored by ProScan, and today our subject is the posterior labrum. We're going to finish many of the posterior labral anatomic syndromes and then finish with a summary of the key areas and things you should look at. So let's get started with one of the more classic lesions that you'll encounter after an acute posterior dislocation of the humeral head relative to the glenoid. When this occurs, especially when there is a blow to the front of the shoulder, the anterior aspect of the humeral head will impact the posterior aspect of the glenoid, creating what's known as a reverse Hill-Sachs lesion. Now, this reverse Hill-Sachs lesion in the past has been considered a fracture because that's all you could see on an X-ray. But on MRI, it can be anything from a contusion to a microtrabecular injury, to a fracture, to a depressed fracture. This one is a very low-grade, ill-defined contusion. Posteriorly, there is a tear between the labrum and the underlying bone, separating the two, but also the periosteum, represented by these small, irregular, low-signal foci, is fragmented. So there is both a periosteal rupture and a labral rupture, although the capsule, while stretched, is still attached to the labrum. This would be considered a classic soft reverse Bankart lesion. In the sagittal or lateral projection, this would be anterior, this would be posterior, the swelling and some of the detachment of the posterior structures from the rest of the labrum is visualized, but not nearly as well as is seen in the axial projection. There's also a small amount of blood and a piece of cartilage underneath the coracoid process. Now, in contrast to the acute injury, when the healing of the glenoid after a posterior dislocation results in a faulty or insufficient glenoid cup, in other words, it's flat, the humerus may continue to sublux or dislocate thereafter. This deformity or insufficiency is often associated with capsular stretching. Here's the capsule. Deformity of the glenoid, as previously discussed. Cystic change in the posterior glenoid, which is present. And in this case, a thin area of hyperintensity separating a fragment of bone from the underlying glenoid. So this would be considered a chronic, bony, reverse Bankart lesion. The Bennett lesion. Another bony lesion, by the way. It's a lesion in athletes that's seen as a traction-related enthesophyte, similar to an osteophyte, from overhead sports, perhaps at the site of the attachment of the posterior band of the inferior glenohumeral ligament, but there's still some debate on this. It's seen in about 20% of baseball pitchers, as described by Wright and others. This traction lesion may begin as nothing more than cartilaginous hypertrophy or overgrowth with a mixture of early osseous change. But as it matures, the osseous change becomes a little more dominant. Here's the traction in the sagittal projection of the posterior inferior glenohumeral ligament band on this area, the green representing the capsule, the yellow representing the labrum and glenoid edge, and the blue representing the hyaline cartilage. Over time, ossification occurs around the posterior aspect of the glenoid due to this traction, seen as a curvilinear area of high density on this axial non-contrast CT. The Bennett lesion may be very challenging to assess and diagnose on MRI. This axial contrast-enhanced study demonstrates a curvilinear dark area posterior to the labrum, which appears a bit truncated. It's a little bit difficult to tell if this is all labrum, if this is labrum and some capsular tissue thickened with it, or whether it contains calcification or ossification. But its very size and the fact that there has been no clinical dislocation should rouse suspicion of the ossified or calcified Bennett lesion. Another injury that you'll encounter very commonly is the capsular stretch. This is extremely frequent in anterior-inferior dislocations where the inferior capsule appears to hang down like a hammock. In throwing athletes who have to abduct and externally rotate the arm, in fact, their arm goes behind their body in the mid-coronal plane, and the hand may rotate all the way behind the back of the ear. To achieve this position, one actually must have capsular plasticity. We see this here on a distended arthrographic view. It's not apparent on the non-arthrographic view where we see the labrum, the capsule, a small amount of hyaline interposition as a normal transition point between hyaline and fibrocartilage, but once we distend the joint, we see how floppy and distensible the posterior as well as the anterior capsule is, as it must be to allow range of motion in the throwing athlete. So in the throwing athlete, this may not necessarily be an injury. It can be and is often normal posteriorly and postero-inferiorly. Another unique and interesting posterior lesion is the reverse glenolabral articular disruption or reverse GLAD lesion, a so-called partial rim tear that involves the deep portion of the labrum but in no way is associated with labral displacement, rotation, or injury to the adjacent capsular tissue. A thin slit or flap-like lesion, not extending all the way through, is characteristic of this reverse GLAD lesion. A famous lesion, although a name that may not be familiar to you as a household name, is the Kim's lesion, also known as the reverse Perthes lesion. What differentiates this from the reverse GLAD lesion, which involves the substance of the labrum but doesn't go all the way through, is its location between the labrum and the hyaline cartilaginous bony complex. The periosteum remains relatively spared or intact. Here's an example of a reverse Perthes or Kim's lesion, perhaps not as well depicted on the T1 weighted image, except for the clear appearance of the medullary bone and cortical bone, which is intact. But on the water weighted image, one sees a small pouch of high signal intensity tissue, which represents accumulation of synovium and thickened inflammatory tissue between the labrum and the underlying bone. This pouch stops right at the intersection between the labro-capsular complex and the periosteum, and the periosteum remains intact throughout. The reverse Perthes lesion, the pouch lesion, or the Kim's lesion. Another type of posterior lesion is the POLPSA, or the posterior labrum periosteal sleeve avulsion, so named because the posterior labrum is detached, but this time the periosteum is not spared. And unlike the Perthes lesion, where the injury requires no separation, just a small crack or very thin space, there is more of a rift in the POLPSA lesion combined with the periosteal insult. Here's an example. The rift between the labrum and the underlying glenoid. There is some, in this case, traumatic plastic deformation of the posterior capsule. We know this because this is not a throwing athlete. And the periosteum is elevated or lifted off the underlying glenoid for quite a distance, much more medial than what we saw with the reverse Perthes or Kim's lesion. Yes, this patient also has innumerable anterior findings that will be described in the end of the summary. The POLPSA lesion, a very elusive eponym. The posterior labrum intact periosteal sleeve avulsion. This time, the labrum is spared or unaffected, but the periosteum is lifted off posteriorly, creating a small triangular rift of vague hyperintensity. Now let's summarize the key areas that we use for analysis in any labral pathology. Let's look at a posterior summary. we're going to evaluate the status of the posterior capsule. In this case, it's a bit distended. Its relationship to the underlying fibrocartilaginous labrum. Is it attached, or is it separated or torn? In this case, it's attached. We'll then assess the relationship of the labrum to the underlying bone. In this case, there is a rift. We'll assess the underlying bone itself. In this case, there's some irregularity. There's also some loss of its overall contour. In other words, it slopes backwards and doesn't quite hug the humeral head in its cup, and a small pseudocyst is evolving. We'll assess the relationship of the periosteum to the underlying glenoid, which is also affected. We'll also want to assess whether there's a piece of bone that's involved in this process. Let's look at an anterior summary now. This is a four-dimensional CT showing 3 dimensions but also surface as well as volume rendering. And in the antero-inferior quadrant, a focus of bony irregularity suggests that this dislocating athlete has a small bony component to their injury. One of the first things you want to do, whether you're anterior or posterior, is assess whether a piece of bone is involved. If you're unsure, then resort to the reliable thin section CT with reformatting that shows in this case a tiny inferior and anterior bony and periosteal insult that otherwise was not appreciable on MRI. Here is the same patient demonstrating a few of the other key summation findings. The patient has a Hill-Sachs equivalent, a bone contusion rather than a fracture, in the expected location near the 12 o'clock position, but slightly more lateral. There is plastic deformation of the capsule as it hangs down like a hammock. The labrum is absent and stripped away. The labrum, at least a portion of it, is attached to a portion of the middle glenohumeral ligament and capsule. The periosteum is elevated and fragmented and difficult to visualize. The tiny bony component that we saw in the CT was never appreciated on any of the MR sequences. So once again, bone, labrum, labro-glenoid relationship, labro-capsular relationship, periosteal to bone relationship. All of these are involved in the assessment, anterior or posterior of the shoulder. And finally, a few interesting views that we may resort to with or without placement of contrast into the joint. One of these is known as the abduction, external rotation, or Aber view. Some people also call it the Deion Sanders view, where the arm is behind the head, or the Heisman Trophy position. It puts the anterior labrum on somewhat of a stretch and allows you to see portions of the anterior capsule and ligamentous anatomy, pieces of labrum, and the deficiency of the anterior glenoid. Another view that we may resort to is the internal and external rotation view. An easy way to achieve this is to put the arm behind the back and with the thumb up, external rotation, with the thumb down, internal rotation. This is valuable for any form of functional instability, where you have a very small flap or an area of hypertrophied labrum that an internal rotation folds in and an external rotation pops out, and the patient experiences a click or an audible clunk and feels the sensation that the shoulder will give way, but on physical examination, there's no dislocation and there is no locking. This is the definition of functional instability. A good way to perform this is with fast 2D gradient echo imaging. So you have the Aber view, the internal rotation view, and the external rotation view, none of which require intra-articular injection of contrast. So this concludes our discussion of the labro, ligamentous, and glenoid anatomic syndromes In this section, we focused primarily on the posterior shoulder, but finished with a flurry, talking about the key examination points using the anterior shoulder as a final example. Thank you and have a great day.